Most lists of pancreatic cancer warning signs are misleading you. And that's exactly why this cancer has one of the worst early detection rates of any major cancer. The symptoms on those lists, jaundice, back pain, sudden weight loss, are real, but they tend to show up after the disease has already advanced, not before. Today, I'm going to walk through those commonly listed symptoms honestly, tell you why they show up late rather than early, and then show you the signals that genuinely do appear early, the ones almost no list ever mentions. By the end, you'll know the difference between information that sounds reassuring and information that actually helps catch this sooner. And you'll understand exactly why most people only learn about the real early signals after it's too late to use them, often from a doctor explaining it only in hindsight. I'm Dr. Evander Hale. I've spent 30 years practicing functional medicine, looking past the surface symptom to find what's actually going on underneath. Today, we're separating what genuinely counts as early from what only sounds early. Here's exactly what we're covering, in order. First, why the pancreas hides problems longer than almost any other organ in your body, a structural reason that has nothing to do with bad luck. Second, the symptoms most commonly listed online, explained honestly, including when they actually tend to appear in the course of the disease. Third, the signals that genuinely do show up earlier, the ones rarely mentioned on any list at all, despite having real research behind them. Fourth, what an actual early detection conversation with your doctor looks like if any of this applies to you or someone you love. Stay through to the end, because the most useful part of this video is the part almost nobody else covers. Here's why this cancer behaves so differently from most others. The pancreas sits deep behind your stomach, against your spine, with no nerve endings positioned to send an early pain signal, and no surface a doctor can press on during a routine exam. Most of the symptoms people associate with this cancer only appear once a tumor grows large enough to physically press against something nearby, a duct, a nerve, another organ. That's a mechanical problem, not an early warning system built into your body. A tumor has to reach a meaningful size before it can interfere with anything else, enough to cause a noticeable symptom in the first place. This is exactly why doctors who study this cancer call it the silent disease. Not because it never produces symptoms, but because by the time it reliably does, it has often already advanced well past the stage where treatment works best. Let's go through the commonly listed symptoms honestly, starting with jaundice, the yellowing of skin and eyes. This happens when a tumor in the head of the pancreas presses against the nearby bile duct, blocking a substance called bilirubin from flowing where it should. Bilirubin then backs up into your bloodstream, turning skin and eyes yellow, urine dark, and stool unusually pale. This is a real, recognizable sign worth taking seriously the moment it appears, and it deserves prompt medical attention regardless of cause. But mechanically, it requires a tumor large enough to physically compress a duct, which means by the time jaundice shows up, the tumor has typically already reached a size well past where doctors would call it early stage. That's the honest, uncomfortable truth behind one of the most frequently cited warning signs. Next Persistent upper abdominal or back pain, another commonly listed symptom. This occurs when a tumor grows into the dense network of nerves surrounding the pancreas, or presses against nearby organs and surrounding tissue. Patients often describe a dull ache settling into the upper abdomen that radiates toward the middle back, sometimes worsening after meals or while lying flat. Like jaundice, this is a real and worth investigating symptom, but it depends on a tumor large enough to physically reach and irritate surrounding nerves and tissue. A small early stage tumor generally hasn't grown large enough yet to do that kind of damage. This is part of why pain from this cancer is so often mistaken for ordinary back trouble or acid reflux for months, sometimes longer, before anyone connects it to the pancreas at all. Unexplained weight loss and a noticeably reduced appetite round out the most commonly listed symptoms. These happen for two separate reasons. First, a tumor can physically press against the stomach, reducing how much food it comfortably holds at any one time. Second, a tumor can interfere with the pancreas producing the digestive enzymes your body needs to properly absorb nutrients from food. So even normal eating provides less nourishment than it should over time. Losing a meaningful amount of body weight over a short period without trying is genuinely a signal worth a doctor's visit, regardless of what's ultimately causing it. But again, this typically reflects a tumor that has grown large enough to meaningfully disrupt either your stomach or your digestion, not the earliest, most treatable stage of the disease that any of us would prefer to catch it at. One more commonly mentioned signal: new digestive changes, including pale, greasy stool that's harder to flush, alongside nausea after eating, particularly fatty meals. This happens for the same enzyme-related reason behind appetite loss: undigested fat passing through your system, rather than being broken down properly the way it should. It's a real physical signal worth mentioning to your doctor, and persistent digestive changes lasting more than 2 weeks deserve a conversation regardless of the underlying cause. But like everything else we've covered so far, this reflects an existing disruption to how your pancreas already functions, which again points toward a tumor that's already established and growing, rather than one still sitting in its earliest, most treatable stage where outcomes are genuinely different. Quick question before we move on. Had you heard any of those 4 symptoms described as early warning signs before today? Drop a yes or no below. I'm curious how common that assumption actually is. So what actually counts as early? The strongest signal, with real research behind it, is mu-onset diabetes appearing after age 50 in someone with no prior history of it. A major study validated this year confirmed that this group carries an 8 times higher risk of an undiagnosed pancreatic cancer already present, sitting quietly behind the diabetes diagnosis itself. This isn't diabetes causing cancer. It's often the reverse: a tumor disrupting the cells that manage blood sugar, with diabetes showing up as an early side effect of the tumor's growth, sometimes well before it's large enough to cause any of the symptoms we just covered. Consider a woman I'll call Diane, a composite built from a pattern researchers see often in their work. Diane was 63, never diabetic, reasonably healthy, when a routine checkup found high blood sugar out of nowhere. Her doctor diagnosed ordinary diabetes and moved on with the standard treatment plan. Nobody asked why this started now at her age with no clear cause behind it. Family history is the second genuinely early signal, and unlike a symptom, it doesn't require waiting for anything to happen at all. Having one close relative, a parent or sibling, with pancreatic cancer meaningfully raises your own risk, enough that established genetic counseling and screening pathways already exist specifically for people who qualify. Consider a man I'll call Robert, also a composite built from a pattern seen often. Robert's father died of pancreatic cancer at 68, found only after it had already spread widely. Robert himself was 55, healthy, with no diabetes and no symptoms of any kind at all. He assumed nothing could be done early, simply because nobody had ever told him that his family history alone was reason enough to ask his own doctor about screening, completely independent of any symptom appearing first. Two more genuine risk factors deserve a mention here: chronic, long-standing pancreatitis, ongoing inflammation of the pancreas, raises risk significantly over time. And anyone with that history should already be discussing monitoring with their doctor on a regular basis. Smoking remains one of the most significant controllable risk factors in this entire conversation, roughly doubling risk compared to someone who has never smoked. And quitting at any age genuinely lowers that elevated risk over time, even later in life than most people would assume helps. None of these four signals, diabetes, family history, pancreatitis, smoking, require waiting for a physical symptom to appear first. That's precisely what makes them more useful than a symptom checklist. They're knowable in advance, often years before any of the symptoms we covered earlier would ever show up at all. It's worth understanding exactly why catching this earlier matters so much, since that's the entire reason this distinction is worth making in the first place. The outlook for someone diagnosed while a tumor is still small and contained is genuinely, substantially different from someone diagnosed after it has already spread to nearby organs or beyond. This isn't a small statistical difference. It's one of the widest gaps in outcomes across any cancer type doctors regularly discuss with patients and families. That gap is exactly why researchers have spent so much effort developing tools around the early signals we covered today, rather than refining the symptom lists further. Because for this particular cancer, the difference between catching it early and catching it late may matter more than for almost any other diagnosis a doctor delivers. One honest reason this gap persists is how medicine itself is structured around specialties. A new diabetes diagnosis typically goes to a primary care doctor or an endocrinologist, neither of whom is generally thinking about the pancreas as a cancer risk during a routine visit focused entirely on blood sugar control. A family history of pancreatic cancer often only comes up if a patient happens to mention it themselves, since it isn't part of the standard intake questions most practices ask. This isn't a criticism of any individual doctor. It's a structural gap between specialties that nobody is specifically responsible for closing. Knowing that gap exists is exactly why bringing these specific questions yourself, rather than waiting for your doctor to raise them first, genuinely changes how that appointment goes. If you fall into one of these higher risk groups, here's what a real early detection conversation actually looks like in practice. People who qualify, generally through strong family history or a confirmed chronic pancreatitis diagnosis, can be referred to specialized monitoring programs, typically run through larger academic medical centers, using a combination of MRI imaging and a procedure called endoscopic ultrasound, where a thin scope captures a much clearer picture of the pancreas than an external scan ever could. This is usually repeated on a yearly schedule, not done once and forgotten about afterward. This isn't something every senior needs to pursue. It's a targeted option specifically for people whose risk profile genuinely warrants it. And it starts with a referral from your own doctor, not a test you simply request and receive on your own. If you don't fall into any of the higher risk groups we've covered today, that's genuinely good news. But it doesn't mean ignoring your body entirely going forward. General awareness still matters, simply without the added urgency of a known risk factor sitting behind it. Routine annual checkups, honest conversations with your doctor about any new symptom rather than waiting for it to resolve on its own, and knowing your own family's medical history well enough to mention it if it ever changes, remain genuinely worthwhile habits for everyone, regardless of risk level. The goal of everything we've covered today isn't to make every senior watching this anxious about their pancreas. It's to make sure the small number of people who do carry a real identifiable risk factor actually know about it, rather than learning about it only after a diagnosis arrives. Bring 3 specific questions to your doctor if any of this applies to you or someone close to you. First, given my new diabetes diagnosis at my age, is there reason to consider this might be secondary to something happening in my pancreas specifically? Second, given my family history, does genetic counseling or earlier screening genuinely make sense for someone in my situation? Third, are there monitoring programs available to me given my own specific risk profile right now? Each question forces a concrete answer instead of a general reassurance and brings exactly the kind of detail that a routine appointment otherwise skips entirely without anyone noticing. Write these down before you go, since it's easy to forget specifics once you're actually sitting across from your doctor with limited time. Here's the honest summary to take with you. The commonly listed symptoms, jaundice, abdominal pain, weight loss, appetite changes, digestive changes, are real and deserve attention whenever they appear, but they typically arrive later than the phrase early warning sign implies to most people. The signals that genuinely arrive earlier, new onset diabetes after 50, family history, chronic pancreatitis, smoking history, don't require waiting for a physical symptom at all to show up first. If this video corrected something you've been told incorrectly before, share it with someone over 50, especially anyone recently diagnosed with diabetes for the first time in their life. Comment below and let me know which of these signals was genuinely new information for you today. If you'd like more honest breakdowns exactly like this one, please subscribe to this channel. This video is for educational purposes only, not personal medical advice. Please talk with your own doctor about your specific situation and risk factors.